when I was getting a little, I said, I got a pretty good idea, you know.
Margaret and Gary Cassie came to Prince George in 1998 to be closer to family. Gary is no stranger to heart disease. He'd had a heart attack in Winnipeg.
He never had a cholesterol problem. He walked every day when the rest were having coffee and a cigarette at coffee break or lunch or eating donuts. He would go out for a big walk. His weight was always good. There was nothing. And the doctors finally just decided it was genetic and stress.
Fast forward from 1998, Gary thought his heart troubles were over, but his troubles returned in 2003.
2003.
2003, you start having trouble again.
And I went down to St. Paul's, had the angiogram and the angioplasty. They put in 5 stents that time.
No, that was the first time. They just did a couple of stents. The next time was the 5.
Next time was the 5.
Yeah, in 06 was the 5, and in 07 you had the bypass.
Yeah.
And then you were down again in 14.
Yeah.
I didn't get any tightness in the chest. I didn't get any pain in the chest like what you hear on TV. You know, so anyway, they took me in there. I was grateful for the paramedics. They were able to triage me through that emergency room really quickly.
That's Rita Wiebe. She, like hundreds of others, suffered a heart attack, actually 2, within a short period of time at the start of the new year. It was shortly after having surgery to insert stents into her kidneys.
When I had my cardiac event, you know, it was sudden, nothing, you know, I had an infection in my body a few days earlier, and within 24 hours after getting out of the hospital for that one, I was then admitted a second time, and that's when I had a 2 cardiacs, like dead cardiacs, in the ER room. So I was fortunate enough to get there by ambulance. I was just very lucky to get there. So that's what happened to me. And then after those cardiac events happened, and I wasn't even aware of it, I just remember coming to, and all of these medical people were peering down at me, and they were talking about a cardiac event that happened in the ER room. And I thought, darn, I missed it.
She was sent to Kelowna by air ambulance.
They rushed me to Kelowna, where they have a cardiac unit there. They said that they were going to put some stents in there, into me. And I thought, well, I didn't know what a stent was. I had no idea what any of this kind of stuff was. I've since found out that at least, you know, I was healthy enough to sustain these stents.
Every trip for Gary and Margaret was a trip to Vancouver for care at St. Paul's. Rita was sent to Kelowna. And they're not alone. The most recent numbers are staggering. For the Northern Interior in 2019, 275 cardiac patients were transferred from University Hospital of Northern BC, another 60 from G.R. Baker Hospital in Quesnel, 20 from St. John Hospital in Vanderhoof, 9 from the Lakes District Hospital in Burns Lake, and 25 from Mackenzie, Fort St. James, Fraser Lake and the Robson Valley combined. Moving to the northwest, 78 cardiac patients were transferred from Mills Memorial Hospital in Terrace, 23 from Prince Rupert, 41 from Bulkley Valley Hospital in Smithers, 11 from Kitimat Hospital, and 16 from Hazelton, Deaslake, Stewart, Atlant, and Haida Gwaii combined. And in the northeast, 65 cardiac patients were transferred from Dawson Creek and District Hospital, 82 from Fort St. John Hospital, 11 from Fort Nelson General Hospital, and 5 from Chetwynd and Tumbler Ridge combined. That is a total of 722 patients transferred out of their home communities in 2019. So where do cardiac patients from Northern Health end up going? 375 of those patients in 2019 ended up at St. Paul's Hospital in Vancouver, and another 174 to Vancouver General Hospital. 157 patients went to Kelowna General, 6 headed to Royal Jubilee in Victoria, and 2 headed to Royal Columbia, while 7 were sent out of the province. Nailing down the cost of all this is challenging, but according to Cardiac Services BC, an air ambulance trip out of Prince George, not out of the region, just Prince George, carries with it a whopping $15,000 bill. But that's just what the taxpayers pay.
This is part of the money spent transferring patient. You know, that's actually, even if it sounds like $15,000 for each transfer, that might cost the system. Actually, there are a lot of other hidden costs. You know, some of our patients sometimes wait for days in hospital, occupy bed in hospital before they get transferred. So that's another, and also the cost to the patient. Most of our patients, they have to find their way back on their own, and in addition to kind of disruption of the entire sometimes family, you have somebody else to go with them as well. You have to be off your work, and it's not the same as somebody really in a close by or a drive distant to a hospital, because it does impact the family, it impacts our patients.
Nor is that cheap. If it's an emergency and you need to get south in a hurry, a return fare between Prince George and Vancouver on average in 2019, when those stats were cited, was between $600 and $650. And then there's the hotel.
For somebody that doesn't have, like, we've got extended medical benefits that pay for most of the air ambulance, but anybody that doesn't have that, just the cost of alone from being able to stay here or having to go to Vancouver, even that is a big thing.
With 268 beds, University Hospital of Northern BC is the largest trauma centre in Northern Health, which serves over 300,000 people in an area that is 600,000 square kilometres in size, a piece of land slightly larger than France. In 2018, just under 20,000 surgeries were performed. Nearly 4,000 babies were born in over 24 hospitals throughout the region. There is a regional cancer centre, a medical school, but there is one glaring omission: limited cardiac care. Paint me a picture of what cardiac services are available here.
So if you look at any kind of cardiac service in general, talking about inpatient acute cardiac service or acute cardiac care, you're talking about also outpatient services and cardiac diagnostics. So we do have elements of all of those. So we'll start with cardiac diagnostic. We'll do a majority of non-invasive cardiac diagnostic, ECGs, Holter, all variety of cardiac imaging, echocardiographies, cardiac CTs, as well as nuclear medicine.
But University Hospital of Northern BC does not have what is called a cath lab.
A cath lab is technically a suite where invasive cardiac procedure could be done. The invasive cardiac procedure, most of our cardiac procedure doesn't require any catheter insertion, doesn't require any injection of contrast or cutting. But when we talk about invasive procedure, it involves a catheter, and now most of the time the small catheter get inserted from the wrist. Actually, it used to be more from the groin, the big artery there, but now most of the catheter get inserted from a small radial artery in the wrist up to the heart, and where they keep it close to the arteries of the heart and be able to inject dye and figure out where the blockage or blockages are.
It is also the means by which PCIs are performed to insert a stent to open up a blockage.
That's part of that, but you also could do a lot of other diagnostic. You could measure pressure. You could also do it from the right side of the heart. There are other also procedure where you could, electrophysiology will be able also to deliver not catheter but almost like wires inside and take mapping of the electricity of the heart and be able to do procedure like ablation as well.
But the only labs in BC are located at St. Paul's Hospital, Royal Jubilee in Victoria, Vancouver General and Kelowna General. Prior to coming to Prince George, Gary Cassie first had heart troubles in Winnipeg, a vastly different experience.
How was your experience up here different than Winnipeg?
Well, of course, in Winnipeg, everything's done right there. You're in the hospital, you're on the ward, you just go down the hall, and there's the angiogram and plastium, and the surgery is all on the same floor.
A little different here.
A little different here, because you got to go to St. Paul's. Because if you had that here, like one time I went down there, I didn't need angioplasty, just they took an angiogram and said everything was fine. See, if they'd done that here, would have been one less trip. So I imagine there's a fair number like that.
for many families, they're in an intimidating and difficult circumstance dealing with healthcare issues. And on top of that, they are away from home, they're away from the places and people that they're familiar with. There's financial cost as we look at, getting yourself to Vancouver, managing your way through that.
The first time was a little unsettling, and there's always a bright spot somewhere. It was after dark when I was walking out to the flight, and I had my overnight bag, and I'm kind of had my head down thinking, I wonder if I'll get there before they do anything. I wonder how he made out on the flight, because it was the first time for us. And this young fella who had some a vest, a high-vis vest on, and that just came out of nowhere. He's one of the workers. He took my suitcase and he said, "You look tired." I said, "Well, yeah." He says, "What's happening?" So I said, "Well, I told him." And he walked me all the way to the plane, took my suitcase up and gave it to one of the girls and said, "Keep an eye on her. She's pretty tired."
Shirley Bond has a very intimate experience with cardiac care.
My husband has had to travel to St. Paul's Hospital numerous times, especially over the last number of years. And that was always a challenging situation for us. And we're one of the lucky families that were able to manage that. And but it's also part of my job. And I have spent so many hours talking to people who have had to travel outside of the city for procedures which very likely could be done here in Prince George.
The city of Thunder Bay has a population of just over 100,000 people. The Thunder Bay Regional Health Sciences Centre serves 250,000 people in the Thunder Bay region and northwestern Ontario, a geographic area the size of France. It is a teaching hospital affiliated with Lakehead University and Confederation College. Sound familiar? It should. Northern Health serves a population of more than 300,000 people. It, too, is a teaching hospital working with the Northern Medical Program. The Northern Medical Program students do get trained in basic cardiac care, but the program is very much looking forward to the new cardiac care centre.
It will certainly be an opportunity for them. Whereas now they see the workup of patients for further cardiac investigation, they get to learn about the treatment and the next steps, but they don't actually see it. And so, to see the patients going through the clinical pathway is probably the strongest learning opportunity they can have. What this new centre will bring is more advanced training in cardiac care that we currently don't have. And in turn, that'll give new learning opportunities for our medical students and residents. And it will also enable us to train more senior residents and fellows, and specifically those who are doing cardiology training and fellowships, which we can't do at the moment because we don't have that infrastructure and resource. So it'll provide new opportunities for training for medical students and residents that we currently have, and will obviously extend their learning. And it will provide new opportunities for new learners to come here and learn advanced cardiology.
The BC Cancer Agency's Centre for the North was a battle unto itself, with the local medical society having to fight tooth and nail, and they prevailed. That facility opened its doors in November 2012, and it has served hundreds of patients from across the region, and it has become an invaluable tool for teaching.
The Cancer Centre has been a huge benefit. They've been able to follow the patient's journey through cancer care. And whereas before they learnt about it, and they certainly learnt adequate and sufficient to be able to practice, now they can follow those patients through. And the same thing will happen with this new cardiac centre.
The Northern Medical Program was built around the premise of train in the North, stay in the North, and the cardiac care unit will help with that.
That will make a big difference to recruitment. We've already shown that our graduates come back to the North to practice. So if we train cardiologists in the North, it's going to help us recruit cardiologists in the North.
In Thunder Bay, Ontario, the Thunder Bay Regional Health Sciences Centre serves a huge region for cardiac care.
Our latest data that we looked at was 60% from Thunder Bay or Thunder Bay District, and then 40% from the rest of the Northern Western Ontario region.
When you saw the numbers, are our numbers comparable to yours in terms of how many people you see, how many people, you still probably have to send people out of town for reason, like perhaps maybe cardiac surgery or something like that. But are our numbers comparable to what you see?
There's approximately 1,000 patients that we see for angioplasty PCI. And then for cardiac caths, probably around the same or a bit lower. And then for pacemakers, it's around 300 off the top of my head. So we're a bit higher, and then approximately 250, and this obviously was a funny year with COVID, that we transfer for cardiac surgery or other procedures that we can't do here in Thunder Bay.
Is recruitment an issue?
Absolutely, it's a huge issue. We have a hard time recruiting specialists, not just cardiologists, but all types of medical specialists to Thunder Bay. Basically, you know, a lot of people want to be in the larger centers, but also it's hard for spouses to find work here. And so those have been major challenges to recruiting and to retention.
Nurses too. Nurses, where we've got a massive shortage with nursing, not just within our hospital, but in the north.
How do you overcome that? You know,
you get creative. More, I mean, with the physicians, I'm sure that we do creative scheduling and things like that to make sure the patient needs are met. But I mean, it's just interesting because my other hat that I wear in the organization is the chief nurse executive, and regionally we need to come up with a nursing workforce or an allied workforce with our local governing body, planning body to the ministry, because it's becoming a big issue, and it came more to the forefront currently during the pandemic.
how important is your facility to the region?
I can absolutely say that it's crucial because a lot of the treatment that we provide is very time sensitive. So when somebody's having a heart attack, we have the saying that time is muscle. So the faster that we can open up the artery, the more likely, the person is to survive, but also to avoid significant complications down the road. So having that sort of treatment available in a timely manner, I would say is very crucial. If it wasn't for the Thunder Bay Regional, those patients would have to, go to Winnipeg or Southern Ontario, and that would be a very significant delay for them.
The community, both locally and regionally, relies heavy on us because of the infrastructure that we do have, as well as the services that we provide, not just cancer, cardiac, stroke, the regional stroke center. So major areas that mental health, obviously, too. So if there was, to Andrea's point, if there was no Thunder Bay Regional, patients would be traveling quite substantially to get care in a timely fashion. I think the biggest piece that's been successful for us and now in our cardiac surgery journey is to start building those foundational pieces, like to start with one area of cardiology and build. And we know we've got a few steps to go, including cardiac surgery, but I think the biggest success factor is to have that vision. So Dr. Lai had the vision with, another cardiologist that's still with us and that came on board. I don't know when he came on board, Andrea, Dr. Negro, but probably not long after, in the late 80s, early 90s. And together they built this vision of cardiology and what it could be. And then, as Andrea had said, Dr. Henderson had brought that vision even closer to us to get to angioplasty here. And then having the vision now of cardiac surgery coming to Thunder Bay within the fiscal year of 24-25 and going through that process with the ministry right now. So the vision is the success piece, but also having the community rally behind you. So the community of Thunder Bay and the region is fully aware of bringing, our hearts at home is our campaign. And, when you've actually had those stories, I lost a dear friend last July that I was very fortunate that Andrea was taking care of him in his initial arrival to the cath lab, but we lost him. Could he have survived? Possibly, if we had some form of cardiac surgery here, even though we probably would have had to still been transferred to Southern Ontario. But it's those stories that hit home that could be your family member, could be your husband, that care close to home, hearts at home has been the force behind a successful campaign that the community's rallied behind. And we've only done a soft launch. We haven't done a major public launch yet. with the foundation as well as within our organization. So the community rally behind that and the patient stories have been the reason, I think, why it's been so successful. Like I said, when you hear them, they are heartbreaking.
Northern Health sends 722 cardiac patients to the Lower Mainland each year. The average medevac flight, $15,000. If each and every one of those 722 patients were sent via medevac, the bill is $10.8 million.
I have to tell you, we did talk to one fella, interviewed him. He was shipped to St. Paul's in 2003, 2006, 2007, and 2014. The first three visits were nothing more than putting in a stent here and there. So, but those are things. This is the, and when you say 722 people shipped out of Prince George, the average cost of a medevac is $15,000 a trip. That's $10.8 million in shipping people out. So for things that really could be done in a smaller area, we don't need a whole surgical tower to do that.
I appreciate the circumstances of the patient you've talked to, and I'm sure he'd also say, I mean, it's moving to hear people who've had heart surgery over that period of time, and I know this from family experience and everything else, and operations that a generation ago, or when you and I were born, or before then, wouldn't have been possible, that you have 4 procedures of some sort, and you're here to talk about how you can improve procedures in 2021. It's fantastic, right? It's something to be proud of in a public healthcare system, and the access that people have, and it's important. So I don't disagree with you that we can make, and we are making, incremental improvements.
I want to today at least put on the table the discussion around cardiac care. Because from my perspective, it is similar to the discussion that took place when we were talking about cancer. Could the North actually facilitate a cancer center, staff it, have quality opportunities? And I can understand, and as I said in my opening remarks, I don't think anyone's expecting us to do every single procedure related to cardiac care, but there are procedures where we have trained personnel, we have people needing to have those procedures closer to home. And so one of the things that we talked about prior to the election was having UHNBC have a discussion talking about cardiac care and having obviously Cardiac Services BC talk about how and when cardiac care could be included in services provided there in northern British Columbia. And in the end of the day, it's not just about quality of care. That does matter, and having it closer to home matters. But there's also fiscal implications to that. By actually providing the service closer to home, there's probably a way to look at how that benefits the system more generally. So I'm a strong advocate of incorporating cardiac care, and I know the minister knows I don't mean tomorrow afternoon. Next month would be good, but you know, as we think about, the thing that I thought was so important was the evolution of care in northern British Columbia. You know, we added it piece by piece by piece. And so I am hopeful that the minister will continue to allow those discussions about the evolution of cardiac care in an expanded university hospital in the north. I think it's time, and we know that that will be, you know, a number of years out.
That was October 18th, 2017. The issue of cardiac care, or the lack of it, at University Hospital of Northern BC is not a new one. Remarkably, the day before the writ dropped for the last provincial election, a Sunday, a surgical tower complete with a cardiac care centre was announced.
Business case takes 12 to 18 months. The good news about the announcement, what it meant is that there's money in the 10-year capital plan. It's proceeding. No concept plan project that's been approved for concept plan has never not proceeded. So we're on a road. There's some details in that road because we're building hospital buildings that are going to serve us for 40 or 50 years. But this change, this is transformative. I don't just think for Prince George or for University Hospital or for the staff there, but for people in the north.
You need capital, investment, and you need also to establish, as of safety, you really have to have a well-established cardiac program with cardiac expertise. Is not similar to any other diagnostic. You could have, potentially the machine and one person operating the machine and everything's done. It's the whole system behind that. It's not just a procedure. It's ability to care for, complex cardiac patient within the hospital, within an acute setting. So it definitely requires multiple steps to establish the expertise, from recruitment of physician, cardiologist, interventionist, also training nurses. So there are a lot of steps that we have to take, or multiple steps that we have to take. And we've already started taking steps here to establish, hopefully cardiac center with cardiac cath lab and PCI capacity or capability.
My question is, since the very beginning, since this whole process got going, I mean, I have a Hansard clip of you from 2017 promising cardiac care. It's always tied to a surgical tower, and I'm not sure why is that.
The facilities aren't what they need to be for all surgeries, and obviously developing a cardiac care team requires the highest level available space to work in. And so it makes sense that those happen at the same time, that we create a new critical care unit with the equipment and the facility that's required to support it. And you can't really do that in pieces.
Health Minister Adrian Dix suggests against adding burden to an already overtaxed system of operating rooms at University Hospital of Northern BC. But Shirley Bond argues that's how things need to get done in the north.
Well, first of all, I very much equate this with what happened with cancer care in northern British Columbia. We had to make the case that there was a need and that it was important. And I'm very proud to have worked on that. That is probably one of the things I am most proud of, to know that we now have cancer care here in the north. And that's exactly what we should have. We should have that with cardiac care as well. And I am a big supporter of adding capacity as it's possible. So if there are procedures that we could be doing, and we have every reason to believe that there are, and certainly, even amazing, thinkers like Dr. Burt Kelly and others in the Northern Medical Society have been saying for a long time that let's look at incremental growth. Of course, we want a cardiac care center, but let's look at incremental capacity. What can we do in Prince George to serve a region? And let's start with that.
Is it possible to, baby steps? I mean, one of the things that I think is of the 722 people that we sent last year, it really is something as rudimentary as getting an angiogram. And maybe there's nothing they can do, but it's a big burden to send somebody all the way to Vancouver just to get an angiogram. Is it possible to start cardiac treatment or a facility with baby steps? You maybe be able to do an angiogram or an angioplasty or a PCI without having the full-blown having to have a cardiac surgeon on hand or whatever. Is that possible? Is it possible to start in small bits and grow?
Well, I think that's the only way to do it, is to start off, pick one piece and focus on one piece and, start off very slowly, make sure that that is very well established before you try to move on to anything more complex. At one point, standalone angioplasty was very controversial. So performing angioplasty in a center without surgical backup. Now it's being shown that that's very safe, and we've demonstrated that here in Thunder Bay as well, that we've been doing angioplasty here now since I would guess 2007 or 2008 without surgical backup. And it is just a case of, starting off very slowly, very, very thorough and meticulous planning. And I think that's the way to go.
So traditionally, that has been kind of the idea that you do have to have a backup cardiac surgery to establish cardiac diagnostic, is invasive cardiac diagnostic, and especially if you're going to do intervention. So if you're going to do diagnostic cath or angiogram without any intervention, you technically don't need that. But kind of the the thinking before that you have to have a cardiac surgery in case if there's emergency, so you have backup cardiac surgery. In BC, that has been the norm, for sure, but that's not across Canada and also across the US and Europe. So in US and Europe, there are many established standalone cardiac cath labs with PCI or intervention capability without having surgical backup. In 2019, and actually after our work here in the north, Cardiac Services BC issued as a position statement, which indicate the requirements for any health authority or center to establish a standalone PCI. So in BC, or in BC technically, we would be able to establish that as long as we meet certain requirements and we establish certain threshold. And the main issue is really establishing a comprehensive, fully functional cardiac program.
According to Cardiac Services BC, a health authority where standalone cardiac cath lab with PCI is proposed must have a regional system of care for coronary artery disease, both in a business case and in a demonstrated service delivery plan, a fully developed cardiac program. A fully developed CSBC cardiac program will have a fully staffed cardiology service with cardiology physician specialists and clinical nurse specialists, a fully staffed closed cardiac care unit or equivalent, diagnostic cardiac services including echocardiology, exercise stress testing, nuclear medicine testing, cardiac CT, electronic ECG system with picture archiving system and communication, adoption of standard order sets for common cardiac conditions. Dr. Faraz Mansour insists expertise is not easy to come by when it comes to specialists.
It's not just doing PCI or angiogram. You have to have the full program supporting that. So that's the kind of end result. You still have to do all the homework and and have the backup to do that. So we have to establish that. And also we have to work on improving access to our cardiac diagnostic, decreasing wait time. So these are steps that have been taken, so far, and we're hopeful at least. COVID, pandemic had slowed things a little bit down, but I think we're on the track of establishing some of those goals at least in the near future. So those are the two main initial goals. While we're doing that, recruitment is it's always a concern for us in the north. It's not as easy, and that we're working on. And we have recruited a cardiologist recently, and we're working on recruiting another and possibly a third one in the coming few years. So that would provide us with a complement of expertise to move us forward to the next step.
While the new surgical tower is in the business case stage with no final detailed plans of how it will look, Dr. Mansour has a picture in his mind of the ideal cardiac care centre to be housed in that tower.
Ideally, it consists of CCU, cardiac unit, comprehensive cardiac diagnostic, as well as outpatient clinics. In addition to the, not just one cath lab, but multiple cath labs that be able to operate and, talk about numbers, but that's really where we are. We'll be able to do simple angiography, diagnostic angiography, but at the same time be able to do interventions like PCIs and, stents. There are many other now cardiac procedures done through catheters. So you never know what's going to happen 10 years from now and what's our capacity or what our capability in even a standalone, cath lab will be able to achieve and be able to do, in the future.
My only concern is speaking to the surgical community here. By the time the business case is approved, 18 months, let's say, it's another 7 to 10 years before, once the shovels are in the ground, that we have a new surgical tower. That's my only concern, is that it's a long time.
I'm concerned too, and I'd like it to be faster. I'd like to be able to conjure it, and we can't do that, right? And we've been waiting a long time, and we've seen this in other cases, right? And And so what I'm trying to do is to do these things without drama, without too much theater, without too much rancor. I think I have a lot of support in this, not just from people involved with the NDP or the NDP government, but the opposition MLAs and everyone else. We're working to get this done. And you have to be methodical and do these things over time, and they take a while. But I do think that it makes an enormous difference when you're moving, when you approve a concept plan, then a business plan, then shovels are in the ground, then people can see. It makes the present better when the future looks better. And the future looks better now. And that's a good thing. And that's something that I think everybody in Prince George can be happy about. And it's a good thing too, because we're going to be asking people to raise some money as well.
But the challenge for Rita Wiebe and everyone who is sent away for cardiac care, whether it's Vancouver, Kelowna or Victoria, you are left to your own devices to get home. Another pitfall to the lack of services in the north.
It wasn't a pleasant experience. It was February. It was 30 below. I went down there in an air ambulance, so of course I had nothing but my pajamas. My daughter, she drove up from Kamloops that day and she picked me up, and it was cold. We were in 30 below weather. It was very cold, and I don't think she was aware that I needed a coat, so I had a blanket around me and my pajamas. And so she lives in Kamloops, so we drove from Kelowna to Kamloops. I stayed there the night, and then she drove me to a 100-mile house the next day. Again, 30 below weather, where my husband met us at a 100-mile house and drove me the rest of the way home. And sitting in a car for that long at a time, even 2 durations of sitting in a car, was really hard, because I also had these kidney stents in that I had gotten a couple days prior to this heart attack happening. So, a long ride there, it would have been so helpful if there was a place to be discharged to in Kelowna. Let me get my bearings a little bit, let me learn how to take my medication, rather than just sort of, well, there you are, you can go home now.
Luckily, she had family and friends to make that happen. For Shirley Bond, her husband Bill's heart journey involved multiple trips to St. Paul's. She counts herself lucky that she's in a position to make those trips with him.
As I said, I'm very fortunate. I was able to be with Bill every time that he was required to be in Vancouver at St. Paul's Hospital, and I am so grateful for that, especially in the last time when in fact Bill passed away at St. Paul's. I was able to be there, not with him, but certainly nearby, and that was important to me. So I have heard the stories of so many families, that struggle with just the inability that they have being beside the person that they care about, and I think Northern British Columbians deserve better than that.
For Margaret and Gary, life would have been far less stressful and far less costly if Gary had been able to receive his care closer to home.
I know that the first time you were flown down to St. Paul's, they did an angiogram on you down there, right?
An angioplasty.
How much of a difference would it have made to both of you if you could have had that done here?
Well, a lot more, because you wouldn't have had the trip at all. Because after that, I came back here and it was fine.
Trip, the expense, extra expenses, and like I say, the first time it happened, my cousin wasn't home, so we didn't call him, and I ended up, and he was kind of anxious, and I ended up sleeping in a big chair, and good thing I'm small, because I could curl up in a chair like a cat and just sleep beside him, and he was a lot more comforted and fine with that.
How much, and here I'm playing devil's advocate here, how much easier or less inconvenient or less troublesome or tiresome or whatever you want to call it, inconvenient, less worrisome would it have been if you could have had those 3 stents done here?
It would have been great if I would have been able to do that here. It would have been, I can talk about if it was all happening here, I probably wouldn't have to walk around for 4 months with these stents in, because there's no cardio unit to address anything else. There's nothing like that in Prince George. So if you have something, you just keep your fingers crossed that nothing else happened. For people that, something else does happen within that 6 months, because they don't like to go in there and do another operation, and that's what they had to do to get the the stents that they had put in there to get them out. And like I say, you couldn't even go to the dentist. You have to have other work done. If you're not in a, I tried to get back into Kelowna to get my kidney stents, dealt with because, at least there was a cardio unit close by. But here, if we have something happen to us that need the attention of a cardio unit, that's a major problem. So it would have been so much easier if there had been a cardio unit here, and that all of that could have happened, that my husband could have been there, and it would have been great, but it didn't happen that way for me.
Thunder Bay, for instance, if you look at other jurisdictions, Thunder Bay has been doing what happened, the surgery or operation, since 2007 without specialized cardiac surgeon. They don't even have a cardiac surgeon in Thunder Bay, but they've been doing it since 2007. Does that kind of,
And it's not good.
anger you a little bit that we can't do that kind of stuff here?
It does, and I feel that special passion too for the people in northern BC, and for not just heart issues, but for all kinds of things. And right now I'm passionate about that whole cardiovascular thing. There's not enough education that is done around the whole cardiovascular, whether it's the heart or whether it's the circulation in our bodies and that sort of thing. I really do think that we need more accessibility to information and knowledge. Even for our YMCA, I mean, all of that was closed down, and they said, well, it's got a 1-year waiting list, and I think people die in 1 year. I'm just so, yes, it would be great if we could do this. It would be great if all those things that I talked about, if I could have experienced them here. I'm sure that even if I would have been in Prince George, I could have still went on the virtual platforms, and because during COVID, COVID's going to be finished soon, but to be able to, some people they don't want to go out right away when they're not feeling so well.
While there are differing points of view as to what should be done in terms of cardiac care at University Hospital of Northern BC, Dr. Mansour says everyone has one goal in sight.
Our goal is to treat majority of our acute cardiac patient in the north.